Hello, my name is Seong, and I'm a urology fellow at Seoul National University Bundang Hospital. It's an honor to present our work at Investigative and Clinical Urology, conducted by our team led by Professor Hakmin Lee. To give a brief background about the study, as urologists, we routinely assess voiding function or dysfunction after catheter removal. And to our knowledge, institutions either opt for self-voiding, which means allowing the bladder to spontaneously fill until an adequate urine amount is achieved, and then testing for voiding, or use retrograde filling, which refers to the technique of artificially inducing a filled bladder with retrograde insertion of sterile solution. One of the limitations of a spontaneous voiding trial is the time and delay caused by waiting for the patient to actually feel the desire to void, which can vary immensely depending on the renal function and or hydration. Retrograde filling is a method to overcome such delays, but while it is widely practiced in actual clinical practice, there is really limited evidence to support its safety and efficacy. Therefore, we decided to conduct a randomized trial in urology patients undergoing TURP for BPH. Total 83 patients were undergoing endoscopic resection of prostate at our institutions, were assessed for eligibility, and were allocated in a 1-to-1 ratio for either retrograde filling prior to catheter removal on day of discharge or to a standard spontaneous void trial without filling. 28 in the RF group and 26 in the spontaneous void group were included at final analysis. The RF group was filled with up to 250 milliliters of sterile saline, or until the patient felt a strong urge to void. Clinical variables including age, prostate volume, preoperative UTI, and urofilmetry findings were included for analysis. A primary endpoint was time to void and time to actual discharge, as well as surveyed questionnaire analysis of both patient and medical staff satisfaction for each procedure. From the results, no significant differences in perioperative clinical characteristics existed in either groups as a result of randomization, but there was a difference in operation methods, as this was decided based on the surgeon's preference at surgery. However, later analysis showed that the type of surgery did not affect successful void nor time to void, so we do not believe this was a critical factor in our results. Retrograde filling showed significantly shorter time to void and subsequent time to discharge by at least an hour without causing any differences in actual voided volume nor postoperative voiding function on urofilmetry. The retrograde fill group showed a lower rate of discharge without recatheterization, with otherwise no differences in immediate postoperative complications or reintervention rates within 3 months. A multivariate analysis showed retrograde filling to be significantly associated with decreased risk of voiding failure after catheter removal. Survey analysis showed no differences in patient satisfaction between the two methods, and patients felt that retrograde filling facilitated discharge without causing increased pain. Medical staff surveys showed overall similar results, with physicians feeling that retrograde filling would further assist the detection of acute urinary retention after catheter removal. To some, this relatively simple RCT showed that retrograde filling is indeed a safe procedure that can facilitate discharge and detection of successful void without causing additional complications. Both patients and staff were satisfied with the overall procedures based on our questionnaire analysis. However, the actual clinical significance of shortening delay in discharge by an hour remains to be assessed, as this difference may be considered significant in some clinical scenarios, such as in same-day discharge or outpatient clinical settings, but not when early discharge is a key factor to the patient. Further research for clinical relevance is required. Thank you for your attention.